Okay, so how can like bench or clinic research apply clinically, or are we clinicians even using it at all? And how? Is that what
Yeah.
you're, okay. Okay, so I'm a clinician and um I don't know what specific questions you have, so you're welcome to ask them, but I would say that a lot of my career was guided by research because I was using evidence-based psychotherapy modalities and I'm a psychiatrist. So I was
Mhm.
also using evidence-based, guidelines for medication management. So all of that is very evidence-based. The stuff I'm doing now, now that the research is coming out in psychedelics, there is a lot of research, but it's bumping up against a lot of problems
Okay.
with because research methodologies can't accommodate this type of stuff, existing research methodologies. I don't know that that's particularly what you're interested in, but that's definitely something that my career has positioned me to observe happening.
Okay.
But that's a kind of unique situation, but it is a big one going on right now in mental health.
I would love for you to explain like what's the difference between a traditional psychiatry and psychedelic psychiatry, and how is it different, and what are the like.
Um, so what psychedelic assisted psychotherapy is, it's actually a psychotherapy modality. So it can be done by psychiatrists like myself if we're trained therapists, or it's done by other types of licensed trained therapists. So it's psychotherapy, but you are giving someone a psychedelic so that they trip, right? So you're altering their perception of reality. They're
Hmm.
perceiving an alternative reality, and then you're doing therapy while they're in that alternate reality.
Hmm.
So it's a very specialized skill set, but it means you're giving people psychedelic trips, but you're using it to help them with their therapy goals and therefore with symptom reduction.
Hmm.
And it's been quite well researched. You can look up and there's a lot of publications out there, and there's a lot more studies being done. The problem becomes that our existing structures for research in this country don't have a way of approaching this because we really don't have anything in place to study something like altering someone's consciousness.
Hmm.
So,
Okay.
if you think about it, the methodology wise, you can see why you would run into hurdles and they have. And then a couple of those are one, it's like almost impossible to have a blinded placebo arm or anything like the blinding is almost impossible on the part of the provider or the participant. Um, that in itself is true for a lot of psychotherapy research, so it's not the end of the world. A bigger issue, though, is that the studies show that people get better, but you can't identify the active variable. Was it this substance, or was it the fact that they experienced an altered reality?
Okay.
So,
You can attribute like some.
what is the functional what is the functional variable there? You can get people better by altering their reality even without a substance.
Hmm.
So,
Okay.
fasting, meditation, breath work, there's all kinds of things that alter someone's consciousness or alter their perceived reality that can actually have healing benefits. So we have
Okay.
data for that. But, when it comes to things like FDA approval, it gets tricky because how do you know it wasn't just the substance, or how do you know it wasn't just the therapist, or what was it? And, you know, so this is where science has gotten kind of jammed up against, what's actually happening on the ground. So what's happening on the ground is people are moving forward with it because it's effective, even with
Hmm.
identifying the active variable. They're just doing what's effective. But on the level of like FDA approval and stuff, these people, the researchers are going, we can't tell what's going on here.
Okay.
Truth.
Okay. Makes sense. I mean, it's hard to control when you have a lot many variables, I guess, right?
Well, I mean, well, it also has some like existential and philosophical things that disturb people. For
Hmm.
example, if I'm giving you a substance like LSD or something, a psychedelic, and you perceive a different reality, like you're now in an altered reality than your normal one, because what you consider reality is based on what you perceive, right?
Yep.
So now you're perceiving a
Yep.
different reality than I am as the therapist.
Yep.
And something that happens in that reality heals your depression. That keeps happening. So if you're the re if if you're the regulatory bodies, what healed your depression? Was it the LSD? Was it me that I do something? Or was it the fact that you went into an alternate reality?
Hmm.
And if it's the alternate reality, then we've got a little bit of a problem because are we saying that that reality is more true than this reality? This is where you get into like the Matrix and stuff like that. Are we in a simulation? Is that reality more real than this one? no, that can't be true. Well, then how come it's so healing? How come people keep going there and getting healed? What's going on? Makes a lot of people uncomfortable. But it's been studied. There's active trials going on right now of some leading universities and hospital and leading researchers, and more coming down the pipeline. So you will hear about it if you haven't already.
Okay, sure. I mean, I will definitely look into it. It really looks interesting, especially like when you talk about reality, it's a really, really touchy subject.
Yeah, it's pretty touchy. I mean,
Because,
it's kind of paradigm shifting, so it's shaking things up a bit.
yeah.
The first big trials for MDMA, which is a psychedelic, went through the FDA approval process, or went through the FDA process, let's say. That basically, what happened is the results were super good,
Hmm.
but when they were evaluating the studies, they couldn't figure out why.
Okay.
And so they're like, we need to do more research. I mean, I'm kind of glossing through a lot of things, but that was kind of the gist of it. They couldn't identify um, what was it that was making this so effective. And
Okay.
and so now there's like, as the new studies come out, they're all wrestling with this. It's a little more philosophical than I think your project is, but
Okay.
that's the world I'm in. So
Okay. I mean, I'm just taking notes if that's okay. How do you assess if a patient, is doing in the therapy and versus, between.
you would use the same outcome markers that you would for any other kind of psychotherapy. So
Okay.
like you're basically, if you're a therapist seeing a client, you're assessing their symptoms as you go along with them.
Mhm.
Like if you have depression and you go see a therapist and they treat you with a style of therapy designed for major depressive disorder, for example, they're going to be tracking what your depression symptoms and whether they're getting better. So it's the
Mhm.
same thing. We're doing symptom assessment. If someone comes in and says, I'm really struggling with this, and this type of symptom, then we're going to do the therapy and we're going to say, what's your level of symptoms now? In a nutshell, that's how it goes, right? You're tracking reduction in symptoms.
Yeah. And if I say so, like, what's the biggest challenge in assessing the patient's symptoms, or like how if the patient is getting better?
Um, okay, I'm going to speak as a traditional psychiatrist. The one of the main challenges is the restrictive and sort of artificial nature of the diagnostic boxes that we are using or are trained to use, which is the DSM-5. You know what the DSM is in psychiatry. So how you arrive at a diagnosis in psychiatry is very structured. It's all published in a manual that's updated periodically called the DSM, Diagnostic and Statistic Manual, I think. And we are required to diagnose based on that. Insurance reimbursement and coding of notes and all these things are kind of based on those diagnoses.
Hmm.
And what happens is that a lot of actual human beings don't fit those boxes very clearly. They'll have some symptoms of one box and some symptoms in another box. And so they end up in these kind of catch-all waste basket diagnostic categories, which used to be called, depression or anxiety or bipolar or whatever, not otherwise specified, meaning it's not in the manual, but they have some symptoms of it. Now it's often called unspecified mood disorder. I mean, they change the names, but the point is a lot of people don't fit the boxes the way they're designed. And that's just one of those realities on the ground. But that is not the fault of researchers, actually, because researchers have to narrow down what they're studying in order to study it. They have to. So you have to have some sort of, if you're going to do a research study for trauma, for example, you have to have people meeting certain criteria. They have to match. They have to all have PTSD according to certain criteria. Otherwise, your data is not useful. So I don't think that's the fault of the researchers. I think that's just the nature of mental health as trying to squeeze something as amorphous and multidimensional as mental health into a science. That's actually what the problem is. So that being said, there's a lot of like um, great research in both psychiatry and psychotherapy, and it's guided the field a lot. It's kept it's kept a lot of like really fringe things from being done, right? Because something has to have some sort of evidence base for effectiveness. So all in all, it's a good thing. It's just that there's inherent limitations when you're trying to take someone's like basic humanness and study it in a kind of science-based way. You've got to artificially narrow what you're looking at.
Hmm.
Um, and people in real life don't quite present that way.
Hmm. Hmm.
That's
And
mental health.
yeah, go on, please.